Good evening, everyone. I am Scott Allen. I am the CEO for the Family Medicine Education Consortium, and welcome to tonight's Family Medicine Residency Showcase. We are going to talk about comprehensive family medicine with the Forbes Family Medicine Allegheny Health Network program. Welcome again. Thank you again for joining us. For those who do not know, let me tell you just a little bit about the FMEC. We are a regional coalition of residency training programs and medical schools. We serve 14 states in the Northeast US and the District of Columbia. We actually have over 200 family medicine residency training programs in that region. Our major activity is we do an annual meeting each fall. It's coming up in about a month in Providence, Rhode Island. So hopefully some of you will be joining us there. We have about 300 medical students that come on scholarships. Um, we also do some awards. We have some learning collaboratives. We have one we're just wrapping up around hereditary breast cancer and narrative medicine, and lots of ways you can get involved with the FMEC. We consider ourselves a catalyst, convener, and incubator. Really, what we try and do is promote family medicine to medical students. So hopefully they will choose that as their career, support residents in family medicine training programs to do scholarly activity, to get some presenting experience and to learn from each other, and support the faculty in those family medicine residency training programs as well. So if you haven't, if you are coming to Providence next month, great, we will see you there. If not, please put on your calendars September 19th through the 21st, 2024 for our annual meeting that year in Philadelphia. We're right downtown at the Philadelphia Marriott. And so with that, I am going to turn it over to Dr. Nikoloff.
Thanks, Scott. We're really looking forward to coming out to FMEC. We're coming out to do a couple poster presentations and just enjoy the conference. So looking forward to Rhode Island. Can't wait. Thanks very much. So hi, everybody. Good evening. My name is Stacy Nikoloff. I'm seeing lots of familiar faces and names here on the screen, which is lovely. My name is Stacy Nikoloff. I'm the program director over at Forbes Family Medicine out here in Pittsburgh. So thanks for joining us tonight. I wanted to just take a little bit of time and, I hope this is kind of an interactive discussion. So I'm going to go through some specific things, just regarding comprehensive family medicine. But I will certainly be happy to answer questions at the end. And like I said, I hope this is sort of an interactive discussion, going throughout our time here together. So just show of hands or verbally, when you went into medical school, did you have a good understanding of what family medicine really was? Can anybody answer that? I see everybody's kind of shaking their heads like, a little bit, yeah, I think that there's sort of a general kind of misunderstanding almost, for what the capabilities, I would say, of what family medicine physicians do in their training, and also that they go on to do when they're done with their training. So what kinds of careers do you think family medicine docs do when they're done with their training? Just curious.
I mean, there's a lot of different things you can go into, but I feel like in school we mostly think of like outpatient, just primary care.
Mm-hmm.
But there's a vast array of things that they can do.
Absolutely. Yeah. And I think that, that is something that's really unique about family medicine, that, you don't have that opportunity in a lot of different careers within medicine. My husband's a rheumatologist. He went to do a fellowship. He's doing rheumatology, and that's great, but that's what he's doing for his career path. And that doesn't really change, and I think with family medicine doctors, you're right, James. I think that, traditionally you think of that as sort of an outpatient career path, typically, seeing patients in the office. But we have residents that go on to do all kind of different things and even change their career path mid-career, to do something new or something, unique. Or, maybe it's that time in their career, they're having kids or they're doing different things. And it's like, I'm going to work urgent care for a while and check that out, or I'm going to be a hospitalist and work 7 days on and 7 days off, because that fits the needs of my family right now, so it's so versatile. And with the fellowship opportunities too, which we'll talk a little bit more about, later. But you can certainly do, inpatient medicine. You could do outpatient medicine. You could also go on to do sports medicine. You could go on to do palliative medicine. So again, I think that there's so much to offer within, a comprehensive family medicine career that you can go lots of different directions, and I think that a lot of people coming into it don't really recognize that, right off the bat. So just wanted to kind of throw that out there to you. So, it's interesting, I think, sort of publicly speaking, when you ask somebody, okay, what is a family doc, right? You hear things like, oh, kind of the jack of all trades, or, oh, that's your PCP, or my favorite, kind of a generalist. You hear that sometimes, right? And I think to myself, that is just such a huge underestimation of the role that we serve, in the community and in the medical world, in and of itself. I interviewed lots of applicants. Obviously, I've been doing this for a number of years, and last year, actually, I had an applicant. I said, right, we're in the middle of the interview, and I said, so why family medicine? And I thought this was such a unique answer. He said, because it's the most challenging field of medicine. And I thought that is really interesting to see it that way, but I think that in many ways that is absolutely correct, that when you're specialized, you have to know a lot about one thing, but as a really solid, comprehensive family medicine physician, you have to know a lot about a lot. And if you're going to be good at it, right, you could be that provider who refers everybody all over the city to every specialist known to man. But if you're going to be good at it, an exceptional family physician, then you have to know a lot about a lot. And that is challenging, and I think that's the biggest challenge really that we face, as family medicine providers. We not only take care of patients' acute needs, right? Think of it this way too. You take care of their acute needs when they're coming into the office for, an urgent thing, or, some kind of acute illness. You're taking care of their chronic illnesses, right? You're managing their hypertension. You're managing their diabetes. You're taking care of their wellness, right? So you're seeing well child checks. You're doing newborn exams. You're doing Medicare annual wellness visits. And you're also considering things that other people don't consider. So you're focusing on, a lot of times, their social determinants of health. What are the barriers to these folks getting care? Do they have transportation? Can they afford their medications? All of those different things that most other providers don't really take into consideration. And that's sort of left to us too, which is a privilege, but it's a big challenge too. I think a lot of you working in family medicine practices have probably experienced that, where you're like, no, this is the medication, and the patient's like, that's great, but it's $900 a month for whatever it is, and I can't do that. So you have to really work with your team, sort of a multidisciplinary approach to taking care of those patients, in order to get them where they need to be. The other thing that I would stress is the mental health aspect of family medicine. So, other than really like psychiatrists and psychologists, we are the ones who are really taking care of folks in that mental health capacity, talking to them about their depression, their anxiety, all these other things that impact their physical health, right? And we do lots of that in the office. So that's something else to consider, when you're thinking about family medicine, is do you enjoy that aspect of taking care of folks? Because you're going to do a lot of it. You absolutely will, within the field. So I think that, when you're considering family medicine as a career path, it's so important for you to choose a residency training program where you are going to really experience that core medical knowledge, that you need, but you're also going to be exposed to lots of different things, so that when you get out of training and you go out into the world to practice, you feel like you've had exposure to many different things within family medicine, right? That can give you that sort of, leg up on, I've really been trained in lots of different things, and not just sort of the core, family medicine. And so we'll talk about some of those things here tonight. So what do you all think about the inpatient experience when you're on family medicine? Do you think that that is essential? Do you think that that's kind of extra? What do you think about it?
I think that I found inpatient to be beneficial because it's a lot faster paced. So it's helped me learn a lot faster than in an outpatient setting, so to speak. And I know we normally think family medicine outpatient, but I think having the inpatient part of it is really helpful for the
Mhm.
learning experience.
Okay. Other
I
thought?
definitely think inpatient is necessary. But also on the other hand, I feel like outpatient, I'm allowed to have more of a one-on-one with my patient and spend a little more time with them and just I feel like communication or creating a foundation with them is so much easier.
Definitely. And when they're not really sick, right? A lot of times you can have those interactions on the outpatient side when somebody is not at their worst, and feeling sort of vulnerable for sure. Yeah. Other thoughts on that?
I also think inpatient's really important, just because you get to see what happens in almost a failure of outpatient medicine. You get to see how to take care of people to make sure that they don't get to that point if you do choose to do outpatient medicine.
Absolutely. That's very true, right? It helps you, when you see folks in the hospital, and this goes for adults and kids. I think it really helps you to triage, in the office and build that skill set where who's really sick and who's not, right? You're able to kind of make that differentiation, based on seeing them in the office versus, in the hospital. Absolutely. No, I get this a lot. We talk about this a lot with the residents, and I think that yes, the majority of folks that go into family medicine end up doing some type of outpatient, practice. But I really firmly believe that the stronger your inpatient experience, the stronger the outpatient doc that you become. And kind of what you were talking about, Natalie, I think that you learn to, again, sort of move at a different pace. You learn to triage people at a different pace. I think that you certainly learn how to communicate with your specialists, with your other teams, and sort of take all that information in, when you're on the inpatient side of things. I mean, at Forbes, we have lots of specialists that work, with the residents and the students, rehab doctors, you're working with social services. And again, you're building those skills and those relationships too, so that when you are, in your office practicing, you have all of those experiences to fall back on, and all of those, those people too, to work with you and help your patients, on the outpatient side too. And the other thing I would say is that, when you walk into a room, I've experienced this, and this really just speaks to the quality of residents. I've walked into a room before on the inpatient service and had a patient say, "Oh yeah, I just saw Kelly," or something like that, and I say, "Well, Kelly's not on the inpatient service right now," and and the patient said, "No, she just stopped by to see how I was doing and check in," and that means so much to people. The fact that you would take a moment of your time and you have that relationship and that continuity with the patient. And so even if you're not the person necessarily on the service at that moment, it means the world. I mean, you can imagine yourself personally, right? If your doctor specifically took a minute and came in just to check on you and see how you're doing. So a lot of the residents do that. They'll follow their patients, on the inpatient side, even when they're not doing it. And I think that continuity, again, when you're really feeling vulnerable, makes a huge difference, to your patients. So I think inpatient's important for sure. Something else that at least we do at Forbes, and I think a lot of programs do, is we run the rapid responses in the hospital. And so you get very good at managing sort of acute situations, and I think that, again, you're kind of learning how to triage who's really sick, who needs to go to the ICU, who can you manage on the floor, those types of things. And it really, I think, speeds up your learning. Their learning curve just goes way up when you're exposed to those kinds of situations all the time. And you have backup, so you're not thrown out there on a limb. Your seniors are there to back you up, but it's a great learning experience, I think, for you to have that time, to be able to do that. So outpatient, obviously, I think that, again, when you're looking at programs, it's great to have a really strong inpatient, robust service, that's busy and has a lot of volume so that you're seeing a lot of this. But I think it's also obviously equally important to have a really good outpatient experience. And sometimes programs are kind of lopsided, they're really great at one and not so great at another, or vice versa. So when you're looking at programs, I think that's so important to be able to recognize that and know that they have that balance on both sides of your experience. So who here has heard of Clinic First or the Clinic First model? Has anybody heard of that? So that's actually fairly new. And I shouldn't say that. Some programs have done it for quite some time. But sort of traditionally, the way family medicine programs would run, it was sort of like you did your rotations, and then when there wasn't anything, let's say your specialist was there on a Monday and Wednesday, your dermatologist or whatever, and then we'd say, okay, well then your clinic will be on Thursday, that type of thing. And so it really put your rotations and your inpatient experience before your outpatient clinic, right? And what we started to recognize was, again, if we're training folks to become really comprehensive outpatient physicians, then that should really be the focus. That should be sort of where it's at, right? And so this whole concept called Clinic First came about, and we just sort of rolled this out at Forbes in July, where every resident now has a specific clinic day that they are assigned. So no matter what rotation you're on, the clinic schedule is built first, and then everything else comes after that. And I think that the residents like that. I think that they like to know when they're going to be in clinic. They can tell their patients. It's improved continuity already, because patients, you don't have to guess or tell them, okay, call in 2 weeks and see when I'm here. It's like, no, I know I'm here every Thursday. So it's helped with procedures. It's helped with lots of different things, that can be scheduled out. And so again, I think that looking for residencies that have that Clinic First model, especially if you really feel strongly that you want to do outpatient practice when you're done, is going to be really important. Specialty clinics. So I always tease the residents at Forbes, and I always say, you're getting trained in all of these things you don't even know you're getting trained in, because you're just like circulating through them, and they're almost like mini clinics within the clinic. So this is what I was referring to earlier, and saying, you could be a good family doc and have sort of the core training, or you could be an exceptional family doc and you could be exposed to lots of different things so that when you go out into practice, you can handle a lot more, right? You can take on a lot more within your own practice without having to refer patients all over the place. So couple of things, that we do specifically at Forbes. So behavioral health, I mentioned this to y'all earlier. We have a behavioralist, Bob. Some of you have worked with him. He's great. He's been around forever at Forbes, and he does counseling with our patients. And so it's amazing to be able to say, to those patients that you're seeing with anxiety or depression, no, we don't have to send you elsewhere. We can do counseling here with you, with Bob. We also have a full-time social worker, that works with us too. So she can kind of help integrate some of those social determinants of health, into that relationship as well, when it's needed. So again, getting some of that training, that behavioral health training, and doing it one-on-one, with your patients and a behavioralist, I think is a great experience, throughout residency. Some of the other specialty clinics that we do, so we have a weight management pathway, we have a diabetes pathway. So in those particular clinics, again, talking about that multidisciplinary approach to patient care, we have a pharmacist, a behavioralist, a social worker, a resident, so everybody kind of works together, a dietitian and on most of those cases as well, to kind of help the patient, really look at sort of full spectrum approach to their care, and not like, well, you should probably go see a dietitian and good luck, and we'll see, let us know how that works out. Everybody kind of puts their heads together regarding these patients and tries to figure out the best possible plan for them to make them the most successful, with trying to manage their diabetes or lose the weight that they want to lose and things like that. So again, when you're looking at programs, I think looking to see, do they have that support system kind of already built in? Because it's really vital. It's vital to your success and the success of the patients as well. We also do sports medicine. We have OMT at our clinic. Actually, I don't know if any of you saw this, but we just played the video today during our practice management meeting. So Dan DeFelice is our sports medicine. He runs our sports medicine track. And he's such a humble guy. He's telling us, I said, oh, how was your weekend? He said, oh, you wouldn't believe it. He said, did you hear about that game at Kiski? So he is the team doc for a bunch of the local schools, and he takes the residents and things with him. Actually, one of the interns was with him at this game, and she'll probably never forget this as long as she lives, because there was about 40 seconds left of the game, and one of the Laurel Highlands players, who's, by the way, already got scholarships for like Pitt and Penn State and Ohio State, he's really something, got hit from the side, and he was down, unconscious. And so Dan, Dr. DeFelice, went running out onto the field and, was assessing him. When the kid finally came to, which it took a bit, he said he couldn't feel anything from the waist down. And so Dan, tried to stabilize his C-spine, stabilize his spine, called 911 and said, get the ambulance here, but then realized he was kind of far out and not close to a trauma center. So once the player said he couldn't feel anything, he said, cancel the ambulance, get me a helicopter. And so they life flighted, landed on the baseball field, and life flighted this kid over to Allegheny General. And Dan's just telling me this story kind of like matter of fact, and I thought, okay, this is family medicine, right? Like, this is sports medicine within family medicine. People don't think of it that way, but he stabilized this kid. And actually on Saturday evening, the mom, who wasn't at the game because it was an away game, the mom called Dan personally at home and said, he has feeling back in his legs. He has a severe concussion, but he's getting better. And thank you so much for all that you did, to get him the help that he needed that quickly. And we had our meeting, we had a big practice management meeting today, and I found the video on YouTube of this game, and I played the last 45 seconds, during our meeting, and I said, look at what you can do. This is really amazing. Of course, Dan was like, oh my God, why are you playing that? He's like, but he was on the ground with this kid. It was impressive. It was really impressive, so again, you can get this training, and you can know what to do in those situations. It was phenomenal. I don't know, as a mom of two, my son used to play football. He doesn't anymore, not because of this, but he didn't play he hasn't played in a couple of years. But I said, I don't know if I would have been poised enough to handle that situation the way you did. He just really jumped in there. So anyway, commendable. But strong sports medicine presence at Forbes and at lots of different programs. If that's something that you're interested in pursuing, you absolutely can get that training during your residency, and ultrasound training too. Point of care ultrasound we're using a lot now in the office as well, to do joint injections and all that good stuff. So that's available. That's something else that I think that folks don't really recognize necessarily, is how many procedures you do in a primary care office. What kind of procedures have you guys done in primary care offices? Anything so far?
Joint injections, a lot of like derm,
Mm-hmm.
A lot of like ear lavages.
Mm-hmm. Anybody else?
IUD insertions, pap smears, a lot of women's health.
Yep, that's right. A lot of women's health and MSK stuff. Yep, go ahead.
I was just gonna say a lot of women's health, we did like some ultrasounding and Doppler of a pregnant mom and stuff outpatient.
Mm-hmm. Absolutely. Yeah, I mean, you're going to do a lot of procedures. We even recently, again, this is all about how comfortable you are and how confident you are in your skills, and so one of our dermatologists who teaches the residents, he's wonderful, Dr. Stuckert, he was struggling getting over to the hospital to do biopsies, so he was at his office and trying to run over and do biopsies, with derm consults and things. And so he talked to me and said, is this a crazy idea? He said, what if we consulted the residents, right, to go and do the actual biopsies, and we sort of work together on the consultation, because he said they want the experience of doing the procedures and doing the biopsies. I can't get there to do them, but I trust you to do them. And then we can kind of interpret the results together and get the patient, treated faster, because, we can get the diagnosis more quickly. And so I thought, this is a great idea. That makes total sense. So, last week or a week before, I was on the inpatient service and we did, I don't know how many punch biopsies. And so again, it's all about how confident you are in your skills, right? And how willing you are to do these things, but absolutely lots of procedures, within family medicine. I don't know that everybody recognizes that, but you'll definitely do lots of procedures. The other thing or things I would say, as far as like specialty clinics, OB, Natalie, you were mentioning, we do sort of family-centered women's health. So we are actually working right now with a midwife center, so that the residents can go and rotate at the midwife center. Dr. Cooper, who works with us, she's very, very focused on family-centered maternity care. And really trying to sort of develop that birth plan with our patients, that are going into the hospital. We work with doulas, and we work with the OBs too. So they're there 24 hours, for backup if we need C-sections. And actually, we're in the process of hiring a family medicine doc who is C-section trained. And so she's going to be joining the program in July, which I can't wait. I think that'll be really, really awesome, and helpful for Dr. Cooper too, to have another person on board to sort of, help out with the OB stuff. So OB addiction medicine is also something that we do, correctional medicine. So all of the residents rotate through the jail. They do women's health in the jail as well as sports medicine in the jail. And those are two things that I think are really unique, to the program, is having that experience also. And all of the residents prescribe Suboxone. So we have we used to have a specific Suboxone clinic, but now it's just kind of opened up to everybody, as far as not like having to do it in that specific period of time, but all the residents are trained and know how to do that before they leave. So I think it's important. And so, we just said, nope, we're going to get everybody trained on doing that. And then we have Dr. Wolf also at the residency, who does HIV care and transgender care. And again, when looking at programs, I think that, again, that kind of shows you, what you can learn depending on who's at the program, and so with our faculty, I think we're in a nice position because everybody's got different interests, so you've got Dan, who's doing sports. We've got, Steve, who's doing HIV care. I do a lot of women's health, lots of different things, that folks are interested in within the program. So it's good to kind of look at that when you're applying, like, do they have a really diverse group of people teaching me, right? Because you want to be exposed to lots of different things and not just one thing or the other. Other things I think that are important, community involvement. So we used to do lots of this, pre-pandemic, and then it was sort of soul crushing during the pandemic that we couldn't get out into the community and do those things that we love to do, So we frequently go over to the senior center in Monroeville and we do talks. They call it like Donuts with Doctors or something like that. I don't know, it's kind of like a cute name. But we just went over there recently and did a whole dermatology talk. It was like geriatric dermatology. And we thought there were going to be just a handful of people there. There were probably 50 people there when we walked in, and everybody's raising their hands asking us about rashes and all kind of stuff. But actually the residents got a bunch of procedures out of it, because then they came to the practice and said, hey, take this off, or can you freeze this, or what have you. But it's fun. It's fun getting out into the community that you serve. We work with a lot of the local schools. We did a talk a couple of years ago. Again, this was pre-pandemic, and we're just starting to see all of this like open up again, talking about health and fitness, and we had all the kids like jumping up and down and checking their pulses and all this kind of stuff. But it's fun, and I think that that's, again, a unique part of family medicine, is that we can go from the senior center to the schools, and have a cool, unique experience with all kind of different groups. Have you guys been involved in community events and things like that throughout school? A little bit?
Yeah, we actually, oh, sorry, didn't mean to interrupt.
Oh, go ahead.
Yeah, we as a school got, our class got trained to vaccinate. So we were able to go ahead and vaccinate for COVID-19 during the peak of when all that happened. So that was definitely a great experience.
Good for you.
I was gonna say, sorry, I came a bit late. My name's Kaylor. I'm a fourth year at PCOM in Philadelphia.
Nice to meet you.
Nice to meet you as well. So I was able to do hypertension screenings at a local church just a few months ago with my SNMA chapter. So that was a local event that I was able to participate in.
That's great. Anybody else? I'm always looking for new ideas, things that we can do that are different from what we're doing. Actually, we're doing a research project right now. This is kind of cool, and brings up another point, I guess, like scholarly activity and research. You want to do some of that in your program too. We're just starting a research project currently with Stanford. Actually, it's a grant-funded research project with Stanford, talking about health and wellness and getting out into green space. And so we're kind of setting up two different groups of folks. One's kind of a control group, and the other is the group that we're giving like very specific instructions to with regard to spending time outside, and gonna see, we're sort of surveying them to see, how does that affect your physical health, and how does that affect your mental health, and all of these different aspects. So actually tonight, I'm missing it because I'm here with all of you, but we're doing our first walk with the doc. And so we have a bunch of patients going with the residents and some of the faculty walking in Monroeville Park, and kind of like talking with them about their health and wellness and that kind of stuff. So I'm going to the one in November, but this was the first one tonight. Actually, the rain stopped, so that was a good thing too. As I was driving home, I thought, oh boy, walk with the doc is going to be a wet walk with the doc, but I think they're in good shape. I think it worked out okay. So yeah. Have you been involved in a lot of like research project or quality improvement projects that you've enjoyed doing?
I really liked the quality improvement project I did this year with AHN. We wrote guides basically for incoming medical students that rotate at all of the AHN hospitals, so like including Forbes, Jefferson, AGH, and even Allegheny Valley, of basically where to find where you need to be and like when, so you don't have to contact people that aren't in the hospital or just look lost and have to ask for help. It's just kind of like the dummy book of where to go in the hospital for each rotation that you're on within AHN. And we've gotten good feedback on it, so I'm happy about that.
Yeah, I bet. I mean, I think that's part of the battle, right? When you're starting anything new, is just kind of having a little bit of a guidebook that provides a lot of comfort for people. So that's great.
Yeah, I was involved in a project like my first year of med school with one of my peers. I'm just starting med school during COVID. It was very hard to socialize and stuff. So we just looked at like what effects the pandemic had on like mental wellness, stress, anxiety, and stuff on first year medical students. Then we put together like a comprehensive packet for our administration and stuff, just like some changes like directly from students, like this is like things you can improve, or like this, like these are things that like we think would help like lower stress, lower anxiety, lower depression. And then like 2 years later, like post pandemic, we rescreened like the first year students and did see some improvements, and like had heard that there had been a lot of like changes made to like the curriculum, giving more free time, just like having more on-campus events. So that was like really cool to see like the increase like in just a couple years, and that like our school actually like listened to some of the suggestions that we had.
Absolutely. Yeah, and I think that's so important, that you are all getting involved in things like that, because again, I say this to the residents all the time. We do something at the residency called ResFac, which is like, it's a resident faculty meeting essentially. And it's all sort of anonymous suggestions, because I don't expect anybody to raise their hand and say, this stinks and you need to change it, but I want that feedback, and I want to know what things you think are working really well and what things that, we need to work on and change. And I feel like that is, I don't know. I think that that's my job, as the program director, is like that forward momentum, right? To always kind of like keep things moving forward. And if we can be doing, something better or improving upon something like that, like you're mentioning, that's where it's at, So I think it's really important that you all give us, that feedback and some ideas on what would improve things. Sounds like that worked really well over there. Any other cool projects you guys were part of? Well, I guess the other thing that I just wanted to make sure that, we had some time, for questions and things. Does anybody have any questions about family medicine, about the training, or, applying? Any questions that you want to throw out there to the group? Happy to answer.
I have a quick question. Um, I guess I've just been wondering in terms of family medicine, like you talked about being able to do a variety of different things, like getting out in the community, getting inpatient, outpatient experience. So I was just curious to know how do you go about balancing taking care of patients as well as maybe getting out in the community and focusing on improving social determinants of health, or any type of community outreach. I'm just trying to figure out how to balance everything.
Yeah. No, and I think that's the challenge. That's we're busy people, right? You have busy careers, and so that's certainly a challenge. I think what ends up happening sort of naturally, not just throughout residency, but throughout your career, is that you will start to identify, there are so many things, right, that you could get involved with. And that, I think, is something that we all struggle with. I want to always say yes, and I want to always try, to do the best I can with lots of different things and lots of different projects. But I think that that's something that you start to identify over time, is sort of like, what am I really, really passionate about? What are the maybe one or two things that I really want to spend some of my time focusing on? And I think that it kind of comes naturally. You're exposed to all of these things, and then you start to kind of narrow and realize, this is where I want to put the effort forth, And so for you, yeah, maybe it is focusing on the social determinants of health, which would mean potentially, going out into the community and talking about some of those things, at your local church or your local senior center or whatever the case may be. You'll see that at most health systems, and certainly at AHN, those opportunities just sort of present themselves. So there are so many community events and different, people talking about different projects and different initiatives, that you'll start to recognize, oh, these are the ones, right, that focus on this specific thing that I want to spend my time doing. And then you'll just be sort of asked, do you want to join? Do you want to participate in this? Do you want to be our resident champion on this particular project? And I think that, again, you can't do it all, because, you're going to need to focus on your training and focus on, your patient care and all of those things. But I think you can certainly pick one or two things that you're passionate about. And I think during your intern year, especially, we try to sort of expose you to all kind of different things, so that in your second and third year, when you're talking about what community events do I want to do, what QI project or scholarly project do I want to focus on, you can begin to put those things together, and then focus your attention on those so that you can balance them out.
Okay, thank you.
Sure.
And I just have like sort of a follow-up question on that. So you talked about like all the different things you can go into with family medicine, and I know that there's like a lot of fellowships that you can do.
Mhm.
But are all the fellowships like necessary? So say you have an interest in sports medicine, could you just finish your family medicine residency and just tailor your practice towards sports medicine, or do you need to complete like a formal fellowship?
No, absolutely not. I think that, again, if you train at a strong program, you can go on to do what you want to do. I think there are specific things, right? So if you want to be, a team doc for the Pirates, right? You probably want that extra training, and you're kind of like moving up in the ranks, within sports medicine. That being said, though, I certainly have other, residents who have said, no, I don't want to do a formal fellowship. I just want to go out and practice. And you'll find this happens very easily and pretty quickly, that when your patients sort of recognize what you're good at and what you're passionate about and what you really enjoy, they kind of start to flock to you. And your practice becomes that sort of naturally. So again, it's a lot of word of mouth, right? So if you take care of one athlete, and then they have a buddy who has an issue, they might tell them, and you see how that goes on. Which right now I'm taking care of like all menopausal women. It's a disaster. But anyway, like everybody's crying every day in my office, but it's okay. But again, I like women's health. I like, and so again, that word of mouth kind of spreads, and you end up sort of naturally caring for those people. So you absolutely do not have to do fellowship to continue on that path, for sure.
Thank you.
Sure. You might change your mind too. That's the other thing I would say. Coming into residency, keep an open mind, because you might, think this is what I'm doing. I mean, I know for myself, I hadn't had my family medicine rotation yet, and I thought for sure 100% I was going to do OB. I loved it. I thought it was great. I had the best experience. I had an amazing like teacher on my OB rotation. I thought, this is what I'm doing. And then in the middle of my, like, I had an elective, and I was in the OR, and I think I was like, 3 C-sections in or something. And I thought, this isn't where it's at. Like, this isn't what attracted me to this. So what is it, like you have to take a step back and think, what is it that really drew me to this? And it was, talking to patients about contraception, talking to them, in their prenatal visits, having those kind of like women's health discussions. It wasn't the OR that did it for me, and so then once I did my family medicine rotation, I thought, oh, this is it. Like, this is where I'm supposed to be. We've had other residents. I had one in particular I'm thinking of. She thought for sure she was going to do sports medicine. She was sports, coming in. That's what she was going to do. Did tons of community events, was like helping out at the schools, with the games and things. And then had her ICU rotation and absolutely loved the palliative aspect of taking care of patients. And she ended up doing a palliative fellowship at Vanderbilt, and now she's doing that. So, we were like, what? I mean, she went like full spectrum from sports, to palliative care. But again, you'll see, you're exposed to these things, and then you kind of recognize like, no, this is what I'm supposed to be doing. So just keep an open mind, going into it. What other questions do you have?
So you mentioned like a lot of great things that your program has been incorporating, like the ultrasound. You have the new OB coming in. I guess like, are there any things that like you guys are like working towards that you didn't mention that you're excited about?
Yeah, I mean, I think that we're sort of always working to, to kind of move things forward and keep growing as a program, I think with incorporating different things. Um, I will say it hasn't been that long since we changed our didactics around, and that's been sort of a work in progress where we used to do just kind of topics like faculty or specialists or that type of thing, but it wasn't systems based, and so that is something that is fairly new at the program, that now we're doing systems based didactics. So we will do like a whole block, like 3 weeks of cardiology, or 3 weeks of pulmonology. And I think that the residents have really enjoyed that, and felt that that was a positive thing and kind of focused us in, on particular topics. And so that's something that we're still, continuing to kind of work on, and improve upon. The clinic first thing, like I said, we just started that July 1st. So there's always growing pains, whenever you start anything new. So that's, again, sort of a work in progress. But I think, again, ultimately we'll be, very successful in the end. And I think we'll get there. So nothing huge, that we're trying to change. I think we're kind of on a roll at the moment, with things going pretty well, but we're always making tweaks and adjustments, for sure. And again, I look to the residents for that, to say, you tell me, where are we at? Do you feel like things are going well? And do you feel like we need to change anything? But nothing huge at the moment, which is a good thing. A little stability will be nice. Like post-COVID, we could use a little, a little stability in everybody's lives, for sure. I think something else just to think about, again, when you're on your rotations and you're working with folks, there's going to be lots of great programs, right? All over the country. You're going to do great rotations. You're going to have great mentors, that you're exposed to. I think that something, that's so important is not just the curriculum or, what your call schedule will look like, but take a look at the people around you and really try to picture yourself there. I mean, you want to be at a place where you feel like, I could fit in here. I feel like the residents will have my back. I will have theirs. It's a true sort of family and a true team. You want to make sure that you're part of something like that. I remember interviewing in a program one time when they hid all the interns, essentially. Like, I didn't meet any interns, and I thought, this is very odd. Like, where are they? And, like, are they okay? Or, so you want to make sure that you're exposed to, the residents, and that you can ask them questions, and that you feel like they're really a cohesive group, and that you'll be sort of welcomed in. I think that's so important, because it will tell you when you're a resident, you're busy and you spend probably just as much time with your co-residents that you do with your family, so you want to make sure that you have a lot of support there, and you do the same for them, obviously. Any other questions?
I had a question.
Sure.
I was wondering if you could talk a bit more about the improvements in continuity of care when you did clinic first that you mentioned you've already been seeing in the past couple months.
Yeah. So, again, I think that some of the things that we were looking to do, a couple of things I would say. We've always had teams or sort of pods at the office. And so, on the team, there's like a third year, a second year, first year, and then usually like an MA or a health coach, and then one of the faculty. And the idea behind that was that, there was more continuity for the patients, right? So let's say you're on your ICU rotation and your continuity OB comes in to be seen, right? But, you're on your ICU rotation and you're not there that day, or something. Then what we're trying to do is to encourage the front desk and the health coaches to schedule that person with someone on the team. So not just a random resident, but somebody specifically on that team, so that when you get together and you communicate as a team, they'll have sort of the background on that patient that they could fill you in, and then when you go to do the delivery, maybe two of you are at the delivery, that have sort of taken care of the patient back and forth. Or one of you does the delivery, the other one does the postpartum follow-up, like those types of things. So I think we're trying to make that sort of a more comprehensive process of like team-based care, and making that pod more important than it was before. The other thing is, yeah, when the residents just had random days that they were in clinic, it made it very difficult for, number one, them to predict when they were going to be there. And so it was hard for them to tell their patients, come back and see me in 2 weeks. And then they look at their schedule and be like, oh, I'm here, I'm there, it's going to be hard for you to see me. This way, the patients can absolutely schedule with them. The schedule's already out and open for 6 months at a time. So again, before, because it was so based on the rotation specifically, we weren't able to open those clinics, that long in advance. And so I think the patients missed out because they were like, oh, when do I call back? And how do I get this scheduled? And, that type of thing. And so maybe they wouldn't, schedule, or they would just pick up the phone on a random day and say, I'll just see whoever's available, and that's fine. So again, for acute visits, I think that's okay. I mean, if you're not there on a Wednesday and a patient calls in and says, I think I have strep throat, I want to see somebody, that's okay. But when it comes to like your annual exam and your wellness exams and those types of things, managing their chronic diseases, you don't want them to see, a random person. You want them to see you so that you're following along and exactly sort of that continuum of care. I think that helps your thought process. Now, the next time you're seeing somebody with hypertension, you remember what that process was with a patient. And I think for the patient, whether they recognize it or not, that is helpful for them too. Some people definitely recognize it and they say, oh, I love being able to schedule in advance. And I love that I know that I can see you, because you develop that rapport and that trust. And I think that the overall care, we started looking, and it's been, again, very short time, but we've started to look at, does improved continuity, improve your hemoglobin A1C? Does it improve your rate of, colonoscopies for colon cancer screening? The fact that you're seeing these patients, on a continuum versus just kind of randomly, does that make a difference? And so I really do think it will, for sure.
Thank you. That was great to hear.
Yeah.
What's the onboarding process like for the interns? Just getting in, adjusting to everything, and bonding with the rest of the team like?
Yeah, so I would say the unofficial onboarding is it's kind of funny. The residents do this from the start. So I remember last year, I thought it was unbelievable. They basically had invited all of the new interns before they even started to a Pirates game. So I didn't even know they had each other's contacts, but again, there's, Snap and Instagram and all these different things, that they're able to kind of find each other and connect. And so I thought it was unbelievable that even prior to orientation, I got a picture from one of the Chiefs. They're all at the Pirates game hanging out together. And I thought, that's great. Like, this is what I want to see, and they're kind of taking it on themselves. So I think that from a social aspect, the interns are welcomed in with open arms, and the residents kind of love that process. In the hospital, there's sort of a formal onboarding process. And so certainly, there's general like AHN onboarding for everybody, talking about hospital policies and procedures and all that good stuff. And then there's Epic onboarding. So have all of you worked with Epic? The EHR Epic? I'm assuming probably everybody's been exposed at some point. So they will meet with you and go through Epic training. It's a little painful, I'll be honest. It's like a day of Epic. Everybody, says that, but they will also help you with like personalization when you're starting. So helping you develop like those smart phrases and different things to incorporate into your notes or note templates and stuff like that. And actually the Chiefs have worked with the Epic people. And so they've really developed like kind of streamline that process for outpatient notes, procedure notes, inpatient notes. And so they share all of that with you during that process. And then we do something at Forbes, and I don't know, I know I was at another program in Chicago before this, and we didn't do this there, but I think it's a good thing to do. We do what's called a continuing orientation. So The interns come in for a week-long orientation. And we always say you'll retain about 10% of what we tell you here during this week, because everybody's just like, give me my pager, my white coat, and let's, get at it. But we talk to them about each rotation, sort of expectations and goals for each rotation, what they can expect with, this provider versus this provider. And the chiefs actually have something kind of, I think, Natalie, what you were talking about was sort of like a guide to, intern survival type of thing. And so, they go through that. The chiefs meet with, all of the interns through that week too. And you'll meet with hospital administrators and get a tour, the different areas and things like that. So it's a pretty formalized process for that first week. And then we have some of the senior residents, let's say you're starting on peds. We'll have a senior resident meet you there the first day and say, like, here's the peds floor. This is where you find this. This is where you find that. This is kind of like the workflow for the day when you're on the peds floor, and kind of introduce you around a little bit. So I think that helps too, just to kind of familiarize, with the space and the folks that are going to be around you. And then we do continued orientation. So for the first 6 months, every Monday in the afternoon, you are sort of set free from your rotation, and we do a continuing orientation session. And the faculty usually will run those. Sometimes the chiefs run those. I'm doing one like 2 weeks actually at the Star Center, which is a simulation center, where we're having mock patients there, and the interns are doing like delivering bad news. So they're interacting with mock patients and again, delivering bad news. And we kind of watch and give them some strategies to help them with that. We do lots of workshops during continuing orientation. So, suturing or other derm workshops. We talk about triaging OB patients, so every Monday there's a different topic. But I think that's when the interns really start to get that orientation, like that true orientation to different things, because again, now you've started, you're kind of in it. And you're not so worried about like, oh my God, this is the first week, of me being here. And the seniors, like I said, they're the most helpful with this. They will certainly, be part of those things and help to get you started.
Thank you so much.
Sure.
Dr. Nikolov, I just had a question, like outpatient with the first years. I haven't worked with them, obviously. I was just wondering, like, in terms of like seeing their patients, like, does faculty see them after the first year, like the interns see them? And then do you do kind of like your precepting together and then decision making as a team type thing? And then, by second year, you graduate from that?
Yes, exactly. So actually that is the rule. So at every program, the interns for the first 6 months, so until January 1st, every one of your patients has to be seen directly by an attending physician. So typically, and we do sort of like graduated clinic, so currently our interns are 3 months in, and so they see 2 patients. So basically 2 patients and a half a day. We're starting to incorporate that third patient. So they get an hour per patient at the beginning. Everyone's new to them. They're doing sort of like a full, sort of assessment. And so basically, yeah, that's exactly right. They'll go in, they'll see the patient, examine them, talk to them, get sort of like the history, and then they'll come out, precept. The patient's still in the room. They'll come out, precept, and then we go back in and, sort of observe, like, the intern talking to the patient and going over the plan with them. That way, if there are any questions that come up, or, a lot of times at the beginning, it'll be like, hey, I think I heard a murmur, not sure. Can you listen to this too and see what you think of this? And then we kind of go over the management plan together. That's exactly right. So that happens until January of the first year. And then by the second part, of the first year, usually you're seeing 4 patients and a half a day. And that will then, start to increase. We have 30-minute visits in the second and third year, typically.
Thank you.
Sure.
So I was talking to a few of the residents about like incorporating OMT into like their practice. And I know you guys have the OMT clinic, but how how often or how much is OMT incorporated outside of OMT clinic itself?
Yeah, I think it really varies, Ashni. I think it's different for each resident. So, like you said, we have those designated OMT clinics. And so during those clinics, we usually have an intern and a senior resident. So they can kind of like go back and forth, with the patients and kind of discuss the patients together. When it comes to sort of your own practice, it really is up to you. I think that some people really enjoy OMT and utilize it quite a bit. We have one resident, Gage, he's one of our third years. He's like better at OMT than I'll ever be. He's incredible at it. And so he incorporates it quite a bit into his practice. I will tell you that he, I think, has started to limit that a little bit by just kind of talking to the front desk and saying, hey, if I have 6 patients in my clinic, I don't want more than 2 OMT patients, because he doesn't want his clinic to just fully turn into an OMT clinic, which it would, because everybody loves him and wants, to see him for that. So again, it really varies resident to resident, but you can kind of build that how you like, honestly. We just want to make sure you get exposure to sort of everything and not just that in your clinics.
Yeah, that makes a lot of sense. And I work with Gage, so I definitely understand where you're coming from on that.
I mean, like, I had a trigger point. He saved my life. Yeah. So much better.
Hello, everyone. Sorry, I might navigate the conversation a little away from clinic work. I'm just curious, and I am not US trained. I am an IMG. I'm just curious about your program. Is your program IMG friendly? What specific attributes are you looking out for in an IMG's application? Do you have a certain cutoff point? I know this is a very nervous period for a lot of people, especially IMGs, and I feel like getting first-hand information from you would also help me navigate how I apply and how I put out my application. So I'm just curious. Thank you.
Sure. Yes, I mean, we are definitely IMG friendly. I know some programs are very specific about that. We are not. We are definitely IMG friendly and look at all applicants, that come through. I would say, the most important thing that we look at is your sort of clinical experience. So, where have you done clinical rotations? Where have you had that clinical experience? We certainly look at years out of medical school. So that is something that we consider, how many years out of medical school, before coming into training. That's something that we look at. I think, at least from my perspective, and I think the faculty would agree, we are looking for really well-rounded candidates. So, I know scores are important, I know grades are important, all of those things, but I think that if you weren't intelligent people, you wouldn't have gotten to where you are today, and so, I think that, again, your experiences, your volunteering experiences, your clinical rotations, and I think interviewing, that's another thing that I think is really important, how you sort of present yourself to the group. It makes a big difference. So again, I don't think there's one thing in particular that I would say, being an IMG, you should do this differently than everybody else. I think that we're really looking for sort of well-rounded candidates, and we go from there.
Great, thank you so much. What is the cutoff for year of graduation? Are we looking at 2 years, 5 years?
5 years.
Okay.
5 years, yes.
Thank you.
Sure. And every program is probably different on that, by the way. That's not a standard. That's sort of our sort of general rule. I think your letters of recommendation too are really important, because I think that is something that, we look at as a faculty. I think, again, once you've done this for a lot of years, you can kind of tell when you're reading a letter of recommendation, is this something that is kind of fair, and it's fine, or is this like a glowing review of somebody? I think if people take the time to write you a really strong letter, especially having a letter from a family physician, that's really important. I definitely recommend doing that. I think that means a lot, and that goes a long way.
Great. Thank you so much. That is very helpful. Thank you.
Sure. How does everybody feel about personal statements? Everybody's smiling. Did you find that challenging to write a personal statement?
I feel like it's one of the hardest parts of the application because it's like the most vulnerable part of the application.
Sure. Definitely.
Dr. Wolf had us edit, had someone come in and help us, edit them. And I will say that was one of the most humbling experiences because she kind of took everything that was like, conversational out of it to make it more like, I guess you could say professional.
Mhm.
So that was like very challenging to go back and say, I need to cut that out and change the wording.
Right.
Very challenging.
Yeah, personal statements are tough. And I think again, speaking to like all of these things that are important, when you're applying, I think a personal statement is one of those things. It really is. I think it says something about you. A lot of times it is it kind of introduces you to people and kind of gives a little bit of personality too, as far as like why you're doing what you're doing and what, why you're going into the field of medicine in general, or, sometimes people share personal experiences, so yeah, personal statements are tough, but I think that it's worth it to take the time to make them really good. It really is. And yes, we do actually read them, or at least I do. I read every one of them. So, all right, guys. Well, it was really nice getting to talk to everybody today. If there's no other questions or anything, I don't want to hold you too long here, but thanks for taking the time to kind of learn more about comprehensive family medicine and about the program. And if you have other questions, outside of this today, feel free to send me a question or shoot me an email type of thing. I'm happy to help and happy to answer if I can. So it's nice spending some time with you here tonight.
Thank you so much, Dr. Nikoloff. Thanks for everyone for joining.
Thank you.
Thanks everybody. Have a good rest of your night.
You too. Bye.
Yeah.
Take care.